Okay, a very good afternoon, my dear friends, colleagues, and seniors. So, today the topic of my talk is pain science and recent advances, a physiotherapist perspective. So, actually, this is a very important topic, and it's also my area of interest, that we want to understand what is pain and what we need to do and what we need to do to alleviate pain by various measures. Now, as per International Association of Study for the Study of Pain, they say that a pain is an unpleasant sensory and emotional experience associated with actual or potential tissue damage or described in terms of such damage. Pain is an emotional experience, tissue damage is not necessary. What does that mean? That means that you don't need an injury or inflammation or anything which can show damage of tissues, but rather it is an emotional experience. That is how they talk about the pain definition. Now, in this era of evidence-based medicine, it is important to question our practice patterns if they have been built on dogma and not on practice evidence. Now, this shows that if you really want to understand the concept of pain, you have to understand that you should have the credible evidence supporting your claims. So, and as far we know that there are many concepts that sometimes we revolve around the dogmas or beliefs, but we don't exactly have the evidence available. So, it is very important for you to have evidence when you are discussing about pain. Now, understanding pain sciences, if someone gets hit with a hammer on his thumb, such experiences are easily understood with a structural pathology model, which supposes pain provides an accurate indication of the state of tissues, and there are 4 key points that you should understand. That pain does not provide a measure of the state of the tissues, that pain is modulated by many factors from across somatic, psychological and social domains, that the relationships between pain and the state of tissues become less predictable as pain persists. And the last point is that pain can be conceptualized as a conscious correlate of the implicit perception that tissue is in danger. So, these are the 4 important concepts you understand when you are discussing about the pain sciences. It is not only the tissue injury, there are a lot of things which has to be taken into consideration if you want to understand the concept of pain. Now, pain, as per Royal Melzack and Joel Katz, they say that pain has been a valuable function. It often signals injury or disease, generates a wide range of adaptive behaviors and promotes healing through rest. Despite these beneficial aspects of pain, there are negative features that challenge our understanding of the puzzle of pain, including persistent phantom limb pain after amputation or total spinal cord transection. Pain is a personal subjective. Now, the neuromatrix theory, it guides us away from the Cartesian concept of pain as a sensation produced by injury, inflammation or other tissue pathology, and towards a concept of pain as a multi-dimensional experience produced by multiple influences. This is what we are practicing now. It is not only the tissue injury. Now, in body and brain, the neurons in our body, in motor cortex, they are grouped by body part. Together, the various body parts form a representative map of your body. It is called as homunculus. The intact body schema in the sensory motor cortex, it is called as S1 representation. Now, if there is anything wrong in the representation, that is something called as central sensitization. Now, if there is abnormal central pain processing rather than an injury to anatomical area, if there is no injury, but there is something wrong with the perception of pain, or there is something wrong with the processing of pain in the sensory motor cortex. What happens is patient still feels pain, but there is no injury. So, if this gets disturbed, it is called as cortical smudging, and brain becomes out of focus. That can cause a kind of perception of pain which we do not have, and there is no injury, but it suggests this, and it has told us that pain is dependent on many factors. Tissue injury is not necessary. Now, we have three chronic pains, three types of chronic pain, that is nociceptive pain, neuropathic pain, and central sensitization. In nociceptive pain, it will explain a source of nociception, a role of the brain or pain matrix. In neuropathic pain, it will explain us about the pain neuroscience underlying neuropathic pain mechanisms, how it happens. And in third, that is the central sensitization, explains pain neuroscience underlying central sensitization of pain. That is very important when you are talking about the neuroscience education, when we are dealing with the primary pain mechanisms of pain of the patient, and why he is getting different kinds of pain. So, you have to understand about all three factors when you are discussing about pain sciences. Now, you might understand that a therapist, when he deals with the pain, they think that I have a toolbox with me, I want to use the best tool. Now, this is something called as toolbox approach. They are about the practitioner, not the client or patient. For these toolbox clinicians, they tend to use their favorite tool first, then fall back on the somewhat random series of other tools if they do not get the response they need. Now, tools themselves will not get you anywhere. What matters is the reasoning process that underpins it all. As per the Dr. Jason Silvernail, that is DPT, he tells that you cannot take a single tool to influence pain. You have to have multi-dimensional approach when you are dealing with the pain, and that is called as pain reasoning. It is very important. Now, there is something called as plausibility is essential in application of existing basic and clinical science to a new hypothesis to give us an idea of how it likely is to be true. We are not starting from scratch with each new question, which would foolishly ignore over a century of hard-won biological and medical knowledge. So, you have to understand that there are important aspects of pain. Pain management of the future should accept plausibility, uncertainty, and complexity. If you do not understand this, you are not going to have effect of pain. Now, as per Professor Dr. Adrian Liu, he says that the more I learn about chronic pain, the more I realize that patients are desperate for help. Healthcare providers have so much to offer, but they do not even know it. So, we have to understand that what are the important aspects therapist should know when he is dealing with the chronic pain situations. Now, there is an experiment was done by Professor Liu, 2014, they published a paper. It is about the therapeutic neuroscience education, how it can ease pain. Now, what they did, if you can see 3 slides are there. In one series, in row 1, she was a high level dancer having chronic pain. When she came to Professor Liu, she was put in the scanner, relaxing, watching a movie, and you will notice there are no red blobs or red dots are not there. In second row, she was asked to move her painful back while in the scanner, and in the second row you can see there are lot of redness is there and red blobs are there. They came on the movement when she moved her painful back. In third row, they took her out of the scanner and they spent 20-25 minutes of pain neuroscience education. They talked about what is the importance of pain education, understanding of pain sciences, and you can see after same thing she was asked to bend her back after giving education. Now, you can see there are minimum amount of red blobs in the third row. That significantly shows that pain can be modulated if you understand about the pain sciences or pain education. Now, Cochrane reviews Many people with low back pain, they become frequent users of healthcare services in their attempt to find treatment that minimize the severity of the symptoms. Now, back schools, they consist of therapeutic programs given to a group of people that include both education and exercises. Now, for the outcome pain, we found very low quality evidence that back school is more effective than no treatment. For the outcome disability, we found very low quality evidence that back school is no more effective than no treatment. For that, we also require RCT and meta-analysis for the future studies. Now, I will share you with some evidences. See, these are the Pedro evidences of 2020, which have for some techniques I will show you. Let me just zoom it. Yeah, they were, see, now this we have the evidence now. Nori 2019, they published meta-analysis and systematic review. They told that therapeutic ultrasound, there is a lack of evidence for the use of ultrasound. You cannot use it for chronic low back pain. We have the data now. Same way, Lee 2019, they published meta-analysis on kinesiotape. They said that there is no significant decrease in the pain intensity. Yes, there is a significant decrease in disability and on ODI scale, but there is lack of evidence supporting use of kinesiotape in low back pain. Then about the PNE, that is pain neuroscience education, there is a moderate quality evidence that it can also have a decrease in pain, but not significant decrease in pain, but also disability and kinesiophobia if you are using pain neuroscience education. So, you have to understand that what evidence is available with us. Now, there is a study which was given by Rosende 2019 on TENS. They told us that TENS is not recommended to use for chronic low back pain. Same way, massage, it is not recommended in low back pain. Also, there is something called osteopathic intervention. There is a paper in 2013 published that osteopathic intervention not recommended due to lack of evidence. We do not have evidence supporting the use of osteopathy. Again, spinal manipulative therapy. It was paper published by Robenstein in 2019. They showed that possible adjunct therapy, they have a very good moderate effect evidence that spinal manipulative therapy can be very effective when you are talking about the chronic pain conditions. So, you should understand that you should have very good evidence when you are talking about the pain science education. Now, recent advances in TNE, that is individuals with chronic low back pain, they also tend to have inappropriate pain cognitions associated with poor treatment outcomes such as kinesiophobia, hypervigilance and pain catastrophizing. That is combined pain neuroscience education with cognition targeted exercise therapy can have very good effect. And exercise acceptance and commitment therapy for chronic pain, that is called as ACT. Study was done by Mary Bird KSA in 2018. They showed that they are satisfied with the intervention. There is also a paper was published in European Journal of Pain. They wanted to check the survey of undergraduate pain curricula for healthcare professionals in the United Kingdom. Now, pain education is variable across within the disciplines and interprofessional learning is minimal. Published curricula for pain education have been available for 20 years, but they are rarely employed, and pain is not a core part of the regulatory and quality assurance standards for healthcare professionals. Now, the hours of pain education is widely inadequate given the prevalence of burden of pain. So, you have to understand that you have to educate patients. They should understand that what is pain cognition, what is perception of pain, how you can influence that. They have the right to understand that pain has to be understood. It is not about tissue injury, but it is more than that. Now, in America, they have chronic pain rehab programs, and they have been used now with very effective treating pain. They have 9 components. First of all, the patient, they go for pool therapy, then for relaxing, then they have stretching and core strengthening exercises program, then they have mild low impact aerobic exercises, then they go for relaxation therapies, then they go for coping skills therapy. Sometimes you feel that a therapist is more effective or is more trained than me, and that can cause a diminishing effect on the therapists. So, you have to understand that they have to tell no, or patients, you have to tell them the no problem. If you are lacking, no problem, you can develop properly. So, this can also have an influence of chronic pain. So, they undergo coping skills therapy where they are taught about the techniques or their drawbacks, and that is importantly used. Then there is something called as weekly individual psychotherapy. It is given to the patients who are suffering with chronic low back pain to ease their pain. And there is also the patients who are on narcotic medications, they are given an individualized non-narcotic medication management. And there is also life work exposure therapy. Sometimes you feel that the boss is very strict, or you don't get that kind of respect or salary. So, there is also this therapy is given to the patient, so that they understand, they cope with the work exposure this one environment. So, that is very important. So, this has been a very good effective program used in and it was a paper published in BJMA in 2015 by Campa. And there is also something called as cognitive functional therapy. Now, this has personal factors and clinical factors. See, persons have beliefs, expectations, cultural content, goals, and readiness for changes. These are all factors which can be modified factors. And clinical factors is that beliefs patient can change the belief, and the clinical skills and training the therapist has, he can definitely have a very good impact on the. Then communication skills is very important. When you are talking with a patient who has chronic pain, you can change, you have to give very effective communicator, that he understands that no, my doctor knows my pain very well and he can help me. Then clinical reasoning skill, it is very important that you should never go by the book. You have to make your own reasoning, that why he is getting this pain and how can I relieve that pain, is very important. And then confidence. If a patient sees that my therapist is very confident to treat my pain, so his half pain goes away. So, these are very important aspects when I am talking about cognitive behavioral therapy. And there are something called as CFT. Now, you have to understand that you have to make sense of pain, exposure with control, lifestyle changes, and there are valued activities, reduced bothersomeness, and pain reduction. So, these are all centered around pain, physician, and cognitive functional therapy. So, if it is used in a very proper way, it can cause a very good effect on the patient's cognitive behavior. Now, what is the implications of PNE and TNE when you are giving a pain neuroscience education? It can have pain decreases, function improves, fear diminishes, thoughts about pain are more positive, knowledge of pain increases, movement improves, muscles work better, patients spend less money on medical tests and treatment, the brain calms down as seen on the brain scans, people are more willing to do much needed exercises. So, this is the very important when you are giving pain education. Now, take home message is that, as Professor Lorimer Mosley says, that to reduce pain, we need to reduce credible evidence of danger and increase credible evidence of safety. If a patient knows that my therapist is very good and he has the evidence, he has knowledge about how to decrease my pain, so that increases confidence to you and that can decrease pain. And TNE PNE is in many ways less about this basic neuroscience education and making someone smarter about pain, but a conversation through a patient-centered approach to explore where a patient may need some information to help them make sense of why they hurt and the treatment options that may be helpful, according to Corey Zimney. So, this is something I wanted to share with you, and I hope that you understand now that pain is not just about the this one, about this is much beyond that. So, I have been working with pain sciences since long time now, and I thought that let us do something which can help patients pain perspective. And this is, you should understand that when you are talking, to know that it is very important that basics of pain should be understood, and that can have a very good effect on patient education. So, that is all I think from my side, and thank you so much Dr. Piyush Jain sir for giving me this opportunity to talk about little bit about pain sciences and what advances we need to understand that it is a multi-dimensional aspect of pain. It is not only about the injury and we have to understand the psychology of patient, the sociology. It is called as biopsychosocial model of pain. So that will definitely have a very good effect on patients' chronic pain, and I hope that